So it looks like you can see my screen okay?
Yep.
Okay, good. All right. Hello, my name is Sweta, and on behalf of the Headache Clinic, I'll be presenting a case report of hemifacial spasms that responded to anti-CGRP antibody medication. This case has been submitted to a movement disorder journal, and the co-authors are Dr. Emery and Dr. Bukhari. A 47-year-old woman with a history of TBI in 2014 presents with 5 months of left involuntary facial spasms that began at the onset of the worst headache of her life. The location's left temporal, and she described it as throbbing with photophobia, phonophobia, nausea, and blurred vision associated with it. In addition to the head pain, she also noticed facial twitching that started 1 week after the onset of her head pain. And the head pain itself has been constant since its start. The facial twitching initially was intermittent, but over time became constant, present while awake, but absent while asleep. This was her exam when she presented. She had intermittent twitching of her left facial muscles, particularly the left orbicularis oculi, bilateral nasalis, left zygomaticus, and left rhizoris. The facial spasm was not suppressed with distraction maneuvers and did not fluctuate in intensity, which suggests against a functional etiology to her facial spasms. MRI of the brain was notable for symmetric frontal encephalomalacia that was unchanged since 2014 CT scan. In addition, she had an MRA that did not reveal neurovascular loop compression of her facial nerve. Many cases of hemifacial spasms are due to compression of the facial nerve at the root exit zone from the pons. EEG showed no electrographic correlate. She attempted these medications with no success, and she was unable to get Botox due to insurance barriers. 2 months after presentation, 2 months after presentation, she was prescribed Ajovy, which is one of the anti-CGRP medicines at 225 every 28 days for migraine prevention. And you won't be able to hear her, but I'm just going to play it for you. And as you can see, her hemifacial spasms have improved. Previously, they were constant, but now they're intermittent. And this was 5 days. This was 5 days after she received her first dose of the Ajovy. She also reported 90% headache improvement at this point of time as well. And so she's just talking about how she has noticed a great improvement in both her spasms, in addition to her head pain. So franunezumab, or Ajovy, is one of 4 auto-injectable medications that came out to treat or prevent migraine headaches. On the far right, there's the new one called Vyepti, or eptinezumab, that came out last year. And currently, there's no specific algorithm in terms of which one to select first. Insurance oftentimes requires at least one injectable option to be done before going straight for the Vyepti. So the question, first of all, is the concurrence of migraine and hemifacial spasms, is that coincidental? In this 2012 Cephalgia article, they talked about 5 total cases at that time of migraine triggering hemifacial spasms. They present 3 of the 5 cases, but they suggest that it isn't a coincidence. And they cited the fact that when the pain is severe, that's when the hemifacial spasm is at its worst. So the next question is, why does anti-CGRP antibody medication improve hemifacial spasm? So one theory is that CGRP acts as a vasodilator, leading to transient compression of the facial nerve. And if you block CGRP, does that prevent that vasodilation from happening and helping with hemifacial spasms? Second is We do know that there are anatomical and functional connections between the trigeminal and facial motor neurons, as evidenced by the blink reflex, where the afferent connection is trigeminal and the efferent is facial. And the anti-CGRP effect at the trigeminal ganglion, is that altering somehow the trigeminal and facial connections? The third theory is they found an increased expression of CGRP in injured facial motor neurons in animal models. So is anti-CGRP working directly on the facial motor neurons to help? And then the fourth is it just because that the pain is reduced, and as a result, the facial spasms are reduced secondary to that? So ultimately, this is one case, but we need more cases of this. It'd also be interesting to treat non-headache hemifacial spasm patients with anti-CGRP medicines to see how they do. And at the next headache-related case presentation for Grand Rounds, we will discuss another interesting non-headache condition improving with anti-CGRP medication. Thank you. All right, and I'll give this back to Rich.
Rich, you're muted.
There I am. When I mentioned this paper, I thought it was brain and machine interfaces, which is why I thought it was fairly routine. But actually, what it is brain-brain interfaces. So to have one brain be able to communicate with another using various stimulation patterns. So it's kind of the old Star Trek mind meld thing. So if you're interested in that kind of whiz-bang stuff, it's a good read. So anyway, I will now turn it over to Chris, who's going to introduce today's Grand Round speaker.
Thanks, Rich. So it's my pleasure today to get to introduce Danielle Howard. I think most of the faculty at this point probably knows Danielle. She came to us from Florida, where she did her undergrad at Florida Atlantic University, and then moved on to University of Miami Medical School prior to coming up to us for residency. I've gotten to work a lot with Danielle over the last couple of years, and even in the last couple of weeks being on service with her was really kind of nice, because here at the end of the year, she pretty much did all the work. I just stood in the corner and didn't do much of anything. Over the last couple of years, watching her grow into the physician she is, she's developed a pretty strong interest in bioethics. She's actually worked with the Duke Ethics Consult team and has been published in a prominent bioethics journal within the last couple of years. And so I'm going to let her take over here in a second, but she's going to be moving on to Boston to Mass General for a neuroimmunology research fellowship for the next couple of years. And then after that, I'm sure on to big things. All right, Danielle.
Thank you, Dr. Eckstein. I'm terrible at Zoom, so let me figure out how to do this. Okay, this is working, right? Everyone can see this?
Yep.
All right. Well, good morning, everyone. Welcome. So, as Dr. Eckstein said, my name is Danielle, and it's a pleasure to be here with you today. He kind of stole my introduction, because I was going to say, for those of you that know me, I really like medical ethics and have been doing it for most of my medical career. So I wanted to do something a little bit different today. And instead of focusing on a neurology specific topic, do something that was relevant to sort of all of medicine. And so today I'll be talking about some of the ethical considerations of cardiopulmonary resuscitation. Thankfully, I have no disclosures for this ethics talk. My objectives today are to do a really quick review of the history of CPR, talk about how do not resuscitate evolved in the United States, and then spend the majority of the time talking about the ethics of CPR in really complex medical cases and end with some code status discussions and my conclusions. I do have some audience participation questions in this talk just to keep it interesting. And so the first one is a case, and I'll get to the question on the next slide. So I'll read it out. Ms. Smith is an 89-year-old woman who has a history of Alzheimer's dementia and at baseline is oriented only to herself and is wheelchair bound. She also has metastatic breast cancer and was admitted after being found down at her nursing home. On arrival, she's found to be septic with a blood pressure of 80, heart rate of 115, white count of 23, and a lactate of 4. She's admitted to the ICU, started on broad spectrum antibiotics, and initially required 2 pressors to keep her blood pressure around 90. 3 days later, she still has a blood pressure around 85. Her white count is now 30, and unfortunately at this point, medical therapies have been maximized. You initiate a new goals of care discussion with her daughter at the bedside. You can answer on polleverywhere.com or text this long thing to 37607. And it's totally anonymous, so just tell me, how likely are you to recommend CPR and intubation for this patient? So it seems like we're on pretty much the same page. I'll be coming back to Ms. Smith later. Thank you all for responding. So I'll start with just a brief history of CPR. We really started seeing it around 1775 when a veterinarian found that by shocking a chicken sard, he could both stop the beating and restart it. 100 years later, a physiologist found that massaging the hearts of animals during surgery could restore circulation. And a few years after that, another veterinarian found that external compression could also provide adequate circulation. The first case of human success in external circulation was Dr. Friedrich Moss in 1891. He advocated that we begin using this, but unfortunately, open heart cardiac massage remained the standard. In 1904, Dr. George Crowell also reported a successful closed chest cardiac massage case, but again, we continued with open heart massage. In 1933, researchers at Johns Hopkins rediscovered external compressions and began combining it with external defibrillation. And in 1957, they unveiled the first portable external defibrillator. In 1960, doctors Kuhlenhoven, Safar, and Jude combined mouth-to-mouth breathing with external chest compressions to invent what we know today as modern CPR. In 1963, the AHA formally endorsed it. It was in the 1960s that hospitals began to incorporate cardiac resuscitation policies, and this is really where we began to see the literature start to mention CPR. I included for you here one picture of one of many reports on how CPR was at the very beginning. This is written by Dr. Sykes, a report on 2 years of his experience. I included him because I thought that he was really exemplary of the mindset at the time. You can see here that he says, it was also recognized that patients with renal, cardiac, or respiratory failure would be a special risk, and it was decided that attempts should be made to resuscitate these only if there was a good prospect of them returning to a reasonably normal existence. This mindset was rampant throughout the literature at the time. In the 60s and 70s, not only was it mostly put forward that doctors should be the ones making the decisions about who should and should not be receiving CPR, but there was also a large mindset that patients who were especially ill, those who were terminal, or those who had respiratory or other causes of arrest should not be resuscitated. There was also a very strong undercurrent of the idea that those who would be especially good for cardiac or for CPR in cases of cardiac arrest were those who had unexpectedly died. And this was sort of a nod to that they might have had a cardiac arrhythmia causing their arrest. So it was during this time that we started to see the earliest do not resuscitates appear in charts. They weren't all written this way. Sometimes people just had red hearts, stars. In the UK, they would write not for 222s. The number that they would call for a cardiac code was 222. You'd also see no code, no Dr. Blue, do not resuscitate, and not for cardiac code. The earliest pushback to this idea that doctors should unilaterally be making CPR and do not resuscitate decisions was in 1980, and it was due to a patient named Sharon Siebert, who was a 41-year-old woman who'd had a traumatic brain injury, who lived at St. Mary's Rehabilitation Center in Minneapolis, Minnesota. She'd been living there for 4 years and hadn't had a change in her clinical status, and yet her physician, William Hedrick, made her do not resuscitate at that time without talking to her father, who was her main family member. Her friend, Jane Hoyt, who's actually an elementary school teacher, found out about this through a fluke. She happened to know one of the nurses at the rehabilitation center and was very upset and took legal action with a strongly worded letter and a restraining order. Her argument was that Dr. Hedrick had made Sharon Siebert do not resuscitate because of her quality of life. And Hoyt says, Sharon does have a quality of life. She can express likes and dislikes and even play tic-tac-toe. Additionally, her medical condition hadn't changed. So why was this done? Hoyt actually won this case. The do not resuscitate was rescinded and the restraining order stayed in place. This case brought about a change in the literature. So the 80s were a state of flux. Although there were still many papers that touted the importance of physician autonomy, citing things like if a patient's case is hopeless and CPR is not indicated, and that physicians should have ultimate control, still existed. But there also began to be more papers citing patient autonomy, saying things like DNR orders can only be entered in a patient's chart if the patient or family member consents to this, and that if a patient requests for the DNR to be rescinded, that should be done immediately. By the end of the 1980s, it was a Joint Commission standard to have a code status policy in your hospital. And in the 90s, it became commonplace for you to be full code unless you requested something different. If you go on the US Library of Medicine webpage today and look up code status, you will find the following page with this statement. If you want to receive CPR, you don't have to do anything. This kind of blanket treatment of all comers of patients was warned about in many of the papers in the 1980s when this debate was still at its peak. I thought that Dr. Annis did a very good job of explaining one of the pitfalls of this kind of thinking. He said, much of the confusion regarding the proper indication for DNR orders is caused by the assumption that either every situation is unique and so no rules can be adopted, or that every situation is fundamentally the same and so should be governed by the same set of rules. In today's medical healthcare system, what we have is the latter. Every patient is treated the same regardless of their medical status. They are a full code unless they request otherwise. In today's talk, I am going to argue for a more nuanced sense of who should and shouldn't be do not resuscitate. In clearer words, the argument being made today is there are medical circumstances in which it is unethical for physicians to offer cardiopulmonary resuscitation, and it would be ethical to refuse it, even if it was requested. I realize this is a fairly big statement. We're going to get into the nitty-gritty of the ethics. Before I do that, a quiz question for you. What is the rate of survival to discharge from in-hospital CPR in all comers? We don't have a lot of agreement here, but some of you are right. A 2011 meta-analysis of 35 studies and almost 100,000 patients found an overall survival to discharge of 17.5%. Now, you may be thinking 17.5% is about one patient in every 5 who survives to hospital discharge. That's not so bad. In this case, why would it ever be unethical to do CPR? The argument that there exists a subset of patients for whom it is unethical to do CPR is based on the concept of futile care. This argument is all over the CPR and do not resuscitate literature. There are multiple definitions of futile care given, and a lot of opinions, and not particularly much consensus. In fact, the American Medical Association Code of Ethics provides not a whole lot of guidance saying it is not possible to offer a single definition of futility, and that the meaning of the term depends on the goals of a particular patient in their own specific clinical circumstances. Despite that, I think it is helpful to talk about some of the defined types of futility that are in the literature, especially the first type, which is the most common cited and the one that I am drawing on today in my talk about that certain types of futility merit CPR unethical. This is that of physiological futility. This is where the treatment cannot achieve the effect desired. The most common example given in the literature is antibiotics for the common cold. Since antibiotics don't work on viruses, this is physiologically futile. Arguing that CPR is in certain cases futile also applies to some other definitions of futility, like imminent demise futility, where the patient will die soon despite proposed medical treatment, or lethal condition futility, which is very similar, where the patient has a terminal illness that treatment will not affect. I also wanted to make a specific mention of a type of futility that's rampant throughout the CPR literature, and that is quality futility or quality of life futility. And this is where the treatment fails to allow the patient to lead an acceptable quality of life. I bring this up today because I want to emphasize that this is not the type of futility that I'm referring to in this talk. Physicians are notoriously terrible at assessing quality of life, frequently undervaluing it. And so in this talk about medical futility, I'm referring mostly to physiologic futility and not at all to quality futility. Once we have decided that any treatment is a futile treatment, the AMA does have a more helpful stance on that. They say that we are not required to offer or provide interventions that in our best medical judgment cannot reasonably be expected to yield the intended clinical benefit or achieve agreed on goals for care. This should make us ask, what is the intended clinical benefit of CPR? And I've included here a poster that I think a lot of us are familiar with. It's the H's and T's. The H's and T's is a mnemonic that is taught during ACLS training on what you should be thinking about while running a cardiac code. The H's and T's stand for the reversible causes of cardiac arrest. And they point us to what the intended clinical benefit of CPR is. CPR is intended to continue perfusion to vital organs and brain long enough for the code leader and the rest of the team to identify and treat the underlying cause of arrest. Unfortunately, CPR in and of itself is not a therapeutic procedure. So are there cases where we know beforehand that the cause of the arrest is not reversible? In that meta-analysis of 100,000 patients, they not only looked at overall survival to discharge, but also risk factors that were associated with different survivals to discharge. And they found that there were several that were associated with a survival to discharge of less than or equal to 3.5%. And most of those are not actually that counterintuitive. So you'll see that if a cardiac arrest was anticipated, if the patient's older than 75, if they had a hematologic or metastatic malignancy, or if they were dependent in any of their ADLs, they had a significantly reduced expectation for survival to discharge. I also want to point out that there are some scores on this list. I want you to ignore the PAR because that's a post-arrest score and not particularly relevant to this ethics talk. But they do mention something called a PAM and a modified PAM, with PAM standing for a pre-arrest morbidity score. And both of those are associated with a decreased percent survival to discharge if their scores are high enough. I've included for you here a table just so you can see what is incorporated in the PAM and the modified PAM. And if we think back to Ms. Smith from the beginning case, if we score her on the PAM, she scored points for hypotension, malignancy, honed down lifestyle, and sepsis, and scored a 10. On the modified PAM, she receives all those scores, but also scores for being older than 70 and having dementia, and scores an 11, both of which are associated with a significantly reduced expectation for survival to discharge. So to summarize what we've talked about so far, if we accept that the purpose of CPR is to keep the vital organs perfused for long enough to identify and reverse the cause of the patient's arrest, and we accept that the patient's medical condition at the time of the code has a significant effect on the likelihood of CPR success, and that there exist new data systems that help us predict this, then we must also accept that there are cases where the patient's medical condition renders CPR a futile procedure. And in these circumstances, we should probably not be offering it. Most of the time that I've had these conversations with my colleagues, the next question I'm asked is, well, what about patient autonomy? Patients have a right to decide what medical treatments they get. This is true to an extent, and the AMA also provides guidance on this. They state, respecting patient autonomy doesn't mean that patients should receive interventions just because they or their surrogates request them. I also went into the American Society of Clinical Oncology database because they work with a similarly complex medical question regarding treatments that are viewed as life-saving. What do they say when patients are not maybe good candidates for chemotherapy? In their clinical guidelines, they state that anti-cancer therapy should only be considered when it has a reasonable chance of working and providing meaningful clinical benefit. They even say that patients with markedly poor performance status or a lack of response to 2 prior chemotherapies should not be offered any further cancer-directed therapy. They go on to say oncologists should feel no obligation to provide an intervention that clinical evidence and the clinician's best judgment suggest will provide no meaningful benefit and may cause harm. So we've talked about how CPR at times may provide no meaningful benefit. Does it also cause harm? I think most of us are aware of the fact that CPR can cause some physical harm in the actual act of chest compressions. I've heard some of my colleagues mention rib fractures when doing a code status discussion. I'm not sure we're aware of how frequently this happens. In one study of 43 post-arrest patients, all of them had lung contusions and rib fractures, and 31 had sternal fractures. But in addition to considering the direct physical harm of chest compressions, we also must consider the physical harm done by the rest of the hospital stay. Out of all comers who receive CPR, ROSC is actually achieved in up to 70% of them. But as we stated earlier, only 17.5% survived a hospital discharge. This means that 50% of patients who undergo CPR end up achieving ROSC and then having a prolonged hospital stay, usually in an ICU setting, but still don't survive. Of those that do survive, 15% have an unfavorable neurologic outcome. So to put this in numbers that are more simple, in 100 patients in a hospital who code, 70% of them will achieve ROSC, 70 of them will achieve ROSC, and 30 will die. Of the 70 that survive, 52 of those, after some amount of a hospital stay, will still die. And of the 18 that do survive, 3 of them will have a modified Rankin scale of 4 or 5 on discharge. We also need to be considering emotional harm and to whom we are applying that harm. Obviously, there's emotional harm to patients and families during pretty much all steps of discussion, the actual code, the post-arrest care. We must think about the fact that offering a decision when the outcome will not vary regardless of the decision made is not the most ethical way to go about things. It makes the physician in a place of dishonesty. It implies that there's more hope than there actually is. And should a patient actually be coded and be part of the 50% that die despite this, they may have to watch their family member in a prolonged critically ill state. I also briefly want to touch on the idea of a slow code. Again, this is anonymous, so just a quick yes or no. Have you ever been present for a slow code in your medical career? It seems like we're pretty evenly split. A recent study in 2020 of 237 residents, attendings, nurses, and APPs at Rush and the University of Chicago found that 69% of them said they cared for a patient in the last year where a slow code was performed. I bring up slow codes for two reasons. The first is that the existence of a slow code offers credence to the idea that there are times that CPR is a futile medical treatment. The second reason I mention them is this. Slow codes are sometimes our response to disagreements over code status. And we need to ask ourselves if this is the way we want to respect patient autonomy. Is it better to offer a treatment we think is medically futile and have no true intention of carrying out? Or is it more ethical to directly challenge patients and refuse procedures with no medical indication? The decision-making process is often emotionally difficult for patients and their family members. And this is true no matter when you're doing it, and it's true even if CPR is medically indicated. But we need to think about whether it's worth putting patients and their families through if there really is no difference no matter what they say. Danielle Kahneman is a famous statistician, author of Thinking Fast and Slow, and famous for his work on how we make choices. And he coined the term intuitive heuristics. He says, when we're faced with a difficult question, we often answer an easier one instead and don't realize that we made that swap. Most of us, at least I have, experienced this when doing code status discussions with patients. The question of, would you like to be full code or do not resuscitate is heard as, do you want the patient to live or die? A recent survey study of 28 patients in the final stages of a cancer diagnosis confirmed that this is often how this question is heard. Choosing to forego CPR was construed as choosing to let the patient die, and this was often extrapolated as either the patient is not worth saving or the family doesn't care enough to save them. Now again, this question needs to be asked of all patients, and in cases where CPR is medically indicated, we can't escape this. But in the cases where CPR is medically futile, it may not be the most ethical thing to force the questions to decide life or death when the answer will not change regardless. A minor point, but a necessary point, is that providing futile care can cause harm to the providers. In that study of responses to the Rush and University of Chicago survey, 75 to 80% of them said that they experienced moral distress when required to run, participate in, or even just witness a code that they believed was medically futile. Another study of 22 residents and fellows interviewed about how they felt providing medically futile care used the following descriptive words to say what they felt about the care provided to the patient: torture, gruesome, abuse, mutilate, and cruel. When asked to describe how they themselves felt providing medically futile care, they used terms like violated and traumatized. There is a litany of medical literature that says that moral distress like this can lead to burnout, loss of empathy, and ethical erosion, and so can change how providers will be treating their patients in the future. So we've come to this. If there are times that CPR is not an ethical option, what do we do? The first answer is not that easy. Sometimes we need to not offer it, and sometimes we'll need to refuse it. But the second part is much easier. We need to not discontinue conversation. Currently, there's all sorts of data that says that providers are pretty bad at code status conversations. Although pretty much every hospital in the United States has a policy saying that we should be assessing for code status on admission, In the studies I saw, this only happened about 30 to 60% of the time. Additionally, even when we do have the conversation, we're often bad at it. In a study of 31 medical residents who were observed having a code status discussion, 100% mentioned mechanical ventilation, which is great, but only 55% mentioned chest compressions, only 32% mentioned intensive care, and only 13% mentioned a likelihood of survival, with the caveat being that 0 of those used any actual numbers. It's important that we do better with our code status discussions, even when CPR is medically indicated. This is partially because patients and families, and often doctors, tend to overestimate the success of CPR. In a study of 1,600 patients older than 18 with one of 9 serious illnesses, they were asked what they thought their likelihood was that they would be surviving a cardiac arrest 2 months out. I don't know if you can see my mouse, but you can see here that 76% of them thought their chances were 50% or better. 60% thought their chances were 90% or better. When the actual number is 17.5% for all comers, and these being people with one of 9 serious illnesses, that gulf is pretty huge. There's also data that shows that patients will change their preferences when they're provided with real numbers. In one study of 287 patients who were asked about their CPR preferences, 41% initially said they would want CPR in an acute illness. When they were then educated that their likelihood of survival was somewhere between 11 and 18%, this number dropped to 22%. So we need to work on our code status discussions. Doing so will improve our code status, improve our instances of agreement between patients and physicians, and may reduce instances where we're actually fighting this. Additionally, even in cases where we believe that CPR is medically not indicated, this will at least provide a data-backed background for why it should sometimes not be offered. So I come to my conclusions. You should have guessed them by now. First, there are times when it is unethical to offer or perform CPR because the available data suggests that it would be futile. CPR can cause physical harm with solid organ contusions, broken bones, and often prolonged hospital stays with intensive and invasive treatments, which are not indicated in the case of medical futility. Offering CPR in this case is sometimes misleading or dishonest, prevents patients and families from adequately preparing for death, puts them through a distressing decision-making process for not much reason, and possibly harms the patient-physician relationship. Additionally, CPR when futile poses harm to providers and can cause long-term effects on the care that they will provide in the future. The second main point is that even if CPR is unethical to offer or perform, discussions with the patient and family are still paramount. Real discussions using actual numbers may help patients and providers agree on a code status and reduce instances where we disagree or where a slow code is needed. Even when we cannot agree with patients, it is still a guiding principle of medical ethics that patients have the right to know what goes on in their own care, regardless of what can be offered. Here is my list of references that no one can read. I'd like to thank the following people. Dr. Eckstein looked through this PowerPoint a couple times for me, and so did several of my co-residents. Dr. Montry actually was the one who pushed me to apply for that publication in the Ethics Journal. My mother, who I believe is listening and has listened to this many times, and all the rest of my Duke family. Thank you.
Thanks, Danielle. Rick had a comment. Rick, do you want to mention it?
Yeah, excellent job, Danielle. I just recently gave a talk about end-of-life conversations to our neuromuscular fellows and found some pretty staggering numbers to support some of what you said at the end. Only 25% of Americans have advanced directives. Only 60% of patients in this country with terminal illnesses have any code status, and only 20% of Americans die in hospice. And so, I mean, I think, one of the messages has to be that these conversations need to happen in people with terminal illnesses. And the question that comes up is who should initiate them? There's an article that you may have come across called After You, where patients with these illnesses say they're waiting for their doctors to broach the subject, and doctors say they're waiting for the patients to bring it up. I mean, I feel like it's our responsibility as neurologists who are taking care of people with these diseases, who understand the prognosis of these diseases better than any other physician that's involved in their care, to start these conversations and follow them through.
More.
Danielle, has there been a move to make CPR not the default?
No, I usually get a lot of pushback when I offer this opinion on medical ethics. So the current stance is the way it is. I tried to find some information on litigation in the United States and how much that sort of plays into this discussion. I couldn't find any on this particular subject, but I found many studies where physicians.
Sorry, but go ahead, Danielle.
I found many other studies where physicians will offer care they either think is inappropriate or futile simply because the patient has requested it because of fear of litigation. So that may play a part.
And Danielle, you and I have talked before about this, but one of my greatest frustrations at Duke in the past 21 years is we spend all this time having these conversations with patients with ALS. And if they wind up in the Duke ER for any reason, the very first thing that happens before a doctor even sees them is that their code status is rescinded. Their DNR is automatically rescinded. I don't understand it, because basically what that means is a doctor the patient's never met now is going to have to go in and have that conversation again.
Right.
And I mean, that may be a piece of low-hanging fruit that we can try to figure out as a healthcare system. It just seems like if one of our doctors has had the conversation and documented it in CPRS, I don't understand why the conversation would be, nullified and have to be had again by a doctor that doesn't know the patient.
Rick, you're saying that's a policy of the emergency room?
It seems to be, Rich. I can give you dozens of examples over the years where my patients that had DNRs wound up in the ER, for some other reason that we didn't anticipate. And the very first thing that happened was their DNR status was revoked. And when I talked to them, they say, no one even asked. It just automatically was revoked when they hit the door. And I got to believe it's some sort of medical legal fear that's causing that to happen. But clearly that should not be happening.
Thank you. Sneha, do you want to make a comment?
Yeah, I just wanted to say, well, first of all, fantastic talk, Danielle. There was a lot of evidence I know that you had to review for that, but you did a really good job of putting it all together. And also, just to add to some of the other comments, people on hospice care actually often live longer than those who are sort of full code, full throttle by anywhere from like a month to a month and a half. So I think it's just another way potentially that we could start to have some of these conversations with our patients.
Yeah. Andrew. Andrew on mute. There you go.
Hey there. Danielle, thank you for that talk. That was great. And I just was hoping you could comment a little bit on the AMA said that there's no clear definition of futility. So I'm wondering, there's a very low likelihood of success for those patients, as you mentioned, but is that futile? And who really is deciding the definition of futility in these cases? Does futile mean 0% chance of success, or is there what number in the literature would you say below this we'd call it futile versus just a low likelihood of success?
So this is a question that comes up a lot in the futility literature on CPR and everything else. The first paper, I think, to really try to define futility as a 1% success or less. But I think we're distracting ourselves by trying to apply numbers. And I think the AMA's discussion and also the American Society of Clinical Oncology, they have some of the same wording that we really use all the time in our clinical practice, but don't think about when it's not a life or death decision. We have to use our best clinical judgment and the data that we have available to us. So I don't know that we can put a number on it, but we should be thinking about what's best for our patients.
Chris?
Yeah, thanks, Danielle. I guess just kind of building on the topic or the point you try to make, I think one of the things where we see people and providers get held up is do you think there's a difference in, not offering kind of a full code status versus actively refusing, when there's a family or patient that has made that request?
Sure. From a medical ethics standpoint, there's no difference between not offering a treatment and refusing a treatment. The end result being that the patient doesn't get the treatment. I think what puts strain on a lot of people's hearts is that there is between not offering a treatment and refusing a treatment, with refusing a treatment being much harder on both the patient, their family, and the physician. But from a medical ethics standpoint, there shouldn't be an ethical difference between them.
Matt Ludke?
Yeah, I was just pointing out that there are a number of instances in Duke Hospital and in other hospitals where active DNA orders aren't revised, but they're just actually ignored and people get resuscitated anyway. Some of it's out of fear of litigation and not being able to communicate with families to confirm, but some of it's just out of missing the DNA order or not being aware of it. So even structurally, in terms of quality practice purposes, we're horrible at this.
And there are also studies that I found that showed that do not resuscitates, even when people are aware of them, about 20 to 30% of the time are intentionally ignored.
Danielle, I'm sorry, was that in the form of you're supposed to do it and you don't, or?
No, the patient has a do not resuscitate order and there's resuscitated in.
Right. Yeah. So does Duke have a place in Epic where your code status is listed? Like Rick said, that if he talked to the family as an outpatient, it gets listed somewhere where it's kind of automatically visible to any physician?
Right under the name, Rich. If you look at the upper left-hand corner of your screen, it's right under the name. It says code status.
Really?
It'll say none, DNAR.
And even that is ignored.
Yes, it's just the DNAR is automatically, it seems to me, rejected when the patient hits the ER door, and this code status becomes none.
Wow.
This was sort of the point of my talk. It's what sort of inspired me to do it, was that our standard of care is full code without really considering anything else, even if the patient has already requested not to be.
Brad Coles has a question. Brad?
Hey, Danielle, great talk. I was just wondering if there's differences in the different subspecialties. To Rick's point, he obviously works with a chronic disease population and has these conversations and probably does a much better job than most. Do ICU docs and others that deal with sort of end of life more commonly do a better job of having these conversations?
I didn't see a breakdown amongst specific types of providers like ICU versus others, but there were several studies that compared medicine to surgery, and the results were really surprising that medicine does a much better job of assessing for code status than surgery does.
All right, well, that was a long list of questions. Clearly it sparked a lot of interest, Danielle. Thank you for your hard work and thoughtfulness on this very difficult situation. Not really much different than when I was a resident 30 years ago. Sounds like we did pretty much the same things they're doing now. Slow codes, 1 a.m. conversations with families in the emergency room all the time. Yeah, maybe you'll be the force to make a difference going forward.
Maybe. You can all say you were there at the beginning.
All right, everyone, have a great day. Be safe.
Thanks.